Need bifocals. Thank you so much. If you know me, my name is Christine Stauber, and I always start things on time. So I'm going to start on time. There may be some people trickling in. I'm welcoming you on behalf of Professor Jelaine Arias, who has been coordinating the Grand Rounds and asked me to remind you all of our next Grand Rounds speaker on November 18th, Lorraine T. Dean, who's an associate professor of epidemiology from Johns Hopkins. But in the meantime, I have the pleasure of introducing our current guest speaker, who is Dr. Jodie Guest, and I will be reading this because there's so many things to share about her work. Dr. Guest is a professor and senior vice chair of the Department of Epidemiology at the Rollins School of Public Health. She's co-director of the Office of Interprofessional Education and Collaborative Practice at the Woodruff Health Sciences Center and the associate program director for the Physician Assistant Program in the School of Medicine at Emory University. She has been the recipient of multiple awards at Emory, most recently the 2022 Distinguished Lifetime Achievement Alumni Award for Rollins School of Public Health, the 2022 and 2020 Rollins School of Public Health Professor of the Year, 2020 Teaching Excellence Award from the Department of Epidemiology, and the 2019 Emory School of Medicine Excellence in Diversity and Inclusion Award. She is also the 2023 Society for Epidemiologic Research Kenneth Rothman Career Achievement winner. Dr. Guest has a broad background in epidemiology and specific expertise in racial, sexual, and gender minority populations, in HIV care, large cohorts, and emergency preparedness. Her work centers on communities with inequitable access, stigma, and systematic barriers to care and science communication. Dr. Guest is also the director of the Emory Farmworker Project, a multi-disciplinary program to provide healthcare to thousands of migrant farm workers each year. Beginning in March 2020, Dr. Guest created and led Emory's outbreak response team for COVID-19, working with poultry plant workers, communities in Middle Georgia, the Mexican consulate in Atlanta, the unhoused in Atlanta, and other communities with limited access to vaccines and testing. She has prepared public health plans for multiple community organizations, including being the Iditarod COVID czar for the 2021 to 2023 races. Dr. Guest also serves as the MPOX advisor for the City of Atlanta. Dr. Guest has played a prominent role in engaging with local and national media since the onset of the COVID-19 pandemic and hosted Emory's weekly video updates about COVID-19. She was awarded Emory's 2021 MLK Community Service Award for her work with her outbreak response team, and she is currently creating Emory's Science Communication Certificate and Fellowship programs. Lastly, she serves on the Board of Trustees for Leadership Atlanta, the Leadership Council for Zoo Atlanta, as faculty counselor for the Emory Board of Trustees, secretary of the University Senate, chair of the Health Committee for the Atlanta Mayor's LGBTQ Advisory Council, and chair of the National LGBTQ Health Conference. So with all of that, I would just like to say welcome. We're excited about your talk and looking forward to engaging after the talk with questions. And just for those online, you won't be able to send questions, but we appreciate your attendance. So let's welcome Dr. Guest to the stage.
Thank you so much. Hello, everyone. It's a real privilege to be here, and I appreciate you all coming out when there's a potential storm coming our way, so thank you for being here. I'm usually a big walker when I talk, but I'm getting over a broken leg, so I'm a little bit more stationary than normal, but we're still going to put this on because you never know when I might start wandering. Again, thank you all so much for this invitation to be here and share some of the work that I did during the pandemic. I'm also going to spend some time talking about what I think we learned and where I think we're going. So you'll kind of see I have this talk in about 3 different sections. Danny, you are on this slide, I believe. So we actually have a person who's in this picture here. So the story starts, the story that I'm working with today starts in April of 2020 when we received a phone call at Emory in our Department of Epidemiology from the Northeast Georgia healthcare system saying that they were anticipating and starting to see bubbles of an outbreak of COVID among the poultry plant workers in Northeast Georgia. And if you're not familiar with the poultry industry in the state of Georgia, it is a huge industry in the northeast part, really Gainesville and Hall County area. And so as most of us were being sent home or had the privilege to try to do our work from home, there were certain groups of people who could not do that. And I think the title of essential worker really we used a lot, but what that really meant was not having the privilege to be at home. And so the poultry plant workers certainly fall within that category. I took that phone call, and the next day I drove to Hall County. And I am a 30-year vegetarian, and went to a poultry plant, perhaps not my favorite place I've ever worked, but I spent close to 12 months working with the poultry plant industry in Northeast Georgia. And the day I drove home after being there, what I realized was anything I might be able to offer, I could not do solo. And so I went to our school and said, can I put together a student team to go with me and figure out what it is we need to do? And so, this is really truly building a plane as you're flying it, is what we were doing. And so my department chair said, sure, we have a bunch of students who need practicums because all of our international practicums were put on hold. And but the one cautionary tale I was told was, please don't kill our students, which generally speaking is something I'm not trying to do. But remembering back to April of 2020 and the remarkable amount of unknowns that we had. And so within a week, we had the student outbreak response team, and we did on Zoom, we practiced how to put PPE on, literally on Zoom, we did PPE training, and then we did nasal swab training on Zoom as well, which is a really entertaining thing to try to do. And then we said, all right, all 11 of us, 10 students and me, we're gonna drive to Northeast Georgia, but everyone has to drive in your own car because I don't want you to get sick on the way up there, and I don't know what we're gonna be encountering. Our very first testing site that we did in Northeast Georgia, we had to beg, borrow, and plead for the PPE and the nasal swabs. They were in such a rare supply at that point. We tested over 1,000 people in 3 hours. We shut down the few people that were out on the road systems in Northeast Georgia and Gainesville. Gainesville police were not particularly pleased with us, but we had a positivity rate of 35% at our first testing site. People were driving in and the virus was like pouring out of their face, and they were so sick, and people were so desperate to get some answers and figure out what to do. This really blossomed into 2 very, very intense years worth of work that we did with student groups, traveling across the state of Georgia and trying to be helpful in areas that had inequitable access to testing or vaccines or information. So it began with this poultry plant outbreak, but really became, what could we do to support communities in need? So in our first month in Northeast Georgia, this is one of the sites. This is actually where people who worked at this one particular poultry plant they would go to get their checks every week. And so we set up in the parking lot there. In our first month, we did 9 different testing sites. We tested over 2,500 people, not including that first 1,000 people in a separate site. Our positivity rate in these 9 sites were between 5 and 30%, depending on who we were testing, if we were testing community members or the poultry plant workers. 25% positivity rate consistently that we saw among the poultry plant workers. And so we did a lot of work with the owners of the poultry plants and said, what can we do to help you both protect your workers, but also support them while they're testing positive? They wanted to require testing. And while largely I believe that is a good idea to make sure testing is super available, it's not a good idea if requiring testing and then people losing their jobs because of it happens. And so we negotiated with the poultry plant owners and managers to say, if you're going to require testing and we're going to do it for you, you have to provide sick leave. You have to provide a way for them to have the testing site that we're running not be something that's going to economically ruin them. And so one of the poultry plant owners, he's the only Latinx poultry plant owner in the United States, he said, not only will I meet you for sick leave, I will actually provide testing sites for all of the people who live with my poultry plant workers, and I will provide 75% sick paid leave for the worker if someone in their house tests positive. He really understood what he was trying to do, and he was really very engaged in trying to protect the community of people that he worked with. and engaging with them in their health. We, in all this time and all the different testing sites, we also did 5 different FDA testing modalities. So if you ever have done a saliva test for COVID, we did the FDA testing for that. We're one of the sites. So we would be doing all sorts of different types of testing and trying out the best modalities, in addition to just making sure we were really getting testing in places where it wasn't available. This really leads to how my work then pivoted in epidemiology. I am an HIV researcher. That's what I did 100% of the time prior to COVID, and I pivoted super, super hard to COVID. I have always had the privilege of doing community work, though, prior to COVID, and so this was a really nice integration of that work for me. And some of the things that really drove the type of work that we did in the next couple of years was making sure what we were doing was super compassionate in nature. We were trying to be very supportive as opposed to very directive in the type of work that we were doing. We were trying to consistently build relationships and listen. And I'm going to talk a little bit more about that in a second. And then trying to be very honest stewards of the data. What do we know? What do we don't know? Why don't we know it? How might something change? And really, when I sat back and started thinking about what that first year was like, it was really about communication. It was all the different levels of the ways that we should communicate by being a public health professional. So, talking through that a little bit, relationships. This picture is super important to me because this is, again, in the middle of that parking lot with one poultry plant. And in this picture, you have the Consulate General for Mexico, you have the Secretary of State of Agriculture for the state of Georgia, you have a Northeast Georgia healthcare system and their nursing staff, and you have students and clinicians from Emory. Typically, you wouldn't see an Emory healthcare system and a Northeast Georgia healthcare system saying, let's go hang out together and do something together. And that is probably unfortunate, but I think it's a little rare to see that kind of collaboration. But this was a really interesting time. And so everyone was all hands on deck to try to do things. And boy, we're so much better when we actually approach our work like that. And so love this picture. What we really wanted to do, though, was partner with our community. So we wanted to both know who was at risk, think about who was at risk, why they were more at risk than other populations, but also what's driving that risk and where might we be able to intervene and where can we not intervene. So we have to figure out other sort of services that we need to put in place. An intervention would have been poultry plant needed to shut down. That wasn't an option. It wasn't an option to send people home to do that work. So what could we do given the parameters that we had? What does the community need? That is not always the same about what the community wants. And if you don't ask the question what they want, what you think they need might actually not matter. And so making sure that we're always approaching it that direction. And then, does the community have a seat at the table? I actually became a member of the Hispanic Business Bureau in Gainesville. I do not live in Gainesville, but it's a super cool group. And so making sure that we were constantly getting feedback. How were we doing? What were we doing right? What were we really doing wrong? And how could we course correct that? I could tell you about those 2 years and traveling across the state. I don't have enough time to tell you all the really random, weird, and sometimes super sad stories about it. But I'll highlight a few other things. That one picture on the previous slide led to a relationship with the Consulate General of Mexico, and that became our home for the next 2 years. Every single month, we were in the parking lot of the consulate providing testing for people who go and receive other services at the consulate. And we would commonly do it at a time when they were doing a food drive or passport support or other things like that. So we lived in that parking lot for a long period of time. And that was a really important relationship for us. And then you also get to do really cool things like I went and did all of the COVID work for the Iditarod race in Alaska. I already had a relationship with that race. I was a volunteer there for a long time. But I was in the middle of remote Alaska when COVID hit in March of 2020. And the state health department said, don't you have an epidemiologist who volunteers for this race? What does she think we need to do? How are we going to get a couple thousand people and all their dogs out of remote Alaska, and how are we going to do that? And so that is one of the COVID prevention plans I was able to put together. This is a picture of actually the winner of the race that year, and we did over 6,000 COVID tests in the middle of Alaska to make sure that the race was not spreading COVID out into communities that are particularly vulnerable because they do not have access to healthcare, and communities that we have a history of killing with diseases that we took out into rural Alaska. I will tell you, COVID swabs shatter in negative 40-degree weather, and it's really, really hard to keep them warm enough to actually make them work. So why these groups? And again, I've just shown you a couple. Danny and I went to Milledgeville, where we did a lot of work because the mayor called us and said there's no testing opportunity within 60 miles of here. And any place that they can go, insurance becomes a barrier. Can you come and do testing with us? And so every place that we really spent our time was not the place where there was a lot of access, but it was about where did we see inequities and where was there lack of access. And so it meant we went to a lot of really unusual places, and it meant we saw and met a lot of really cool people across the state. But the commonalities between all of these places is most of it was based on inequities based on racism. And so this is all happening at the same time that we see Black Lives Matter movement, marches and protests and awareness happening. And so a lot of the work that we did was about how could we engage with community and not cause more fear, and how could we engage in community and not put them at risk. Because if we all of a sudden are doing a testing site and we have police on site with us, police who are there to help, are we going to then have it be a barrier to who will come? And does it look like we're a risk? And so really trying to figure some of that out. I'm going to pivot for a second and tell you about some additional work in Atlanta. So we were all just kind of starting to take a breath from COVID, and then Mpox came sweeping through, and it was really, of course, of major concern. And so already working with the mayor's office on people experiencing homelessness in Atlanta and the COVID work for that, they asked me to step up and help with the Mpox work. And so as we watched it approaching, this is the darker states here are having the highest rates of Mpox, and by proportion, Mpox was very small compared to what we saw with COVID, very tiny, but we really didn't know how big it could get, and any Mpox is too much. And so thinking it through, when you look at the states, I don't know if you all can see this red dot, Georgia is down here in state number 5 for the number of cases of Mpox, but if you take Fulton County, if Fulton County was a state, we would have been the 7th state in the country for Mpox. Fulton County by itself had such a disproportionate number of cases compared to almost any other county in the country. And so we were able to negotiate with the CDC to get some of the first Mpox vaccinations. A bit of a story, though, as we looked at who was most at risk and where we were seeing the majority of the Mpox cases. We were seeing them in Black and African American men who have sex with men in the city, or people who have sex with men who have sex with men. But our very first vaccine event went, we had 200 doses, and it went almost exclusively to white men who have sex with men, because what we used for a sign-up for our vaccination was the same sort of sign-up we were using for COVID. And so that meant, did you have the privilege of having a computer? Were you on the computer at the exact moment those appointments opened? Because they were done in 5 minutes. So we quickly figured out that the way we were distributing vaccines or planning to distribute them was not going to hit the right community. It's not like we didn't want other groups to have the vaccines, but we were not appropriately supporting the community that was seeing the most burden of the disease. So we redid our vaccine strategy and our rollout strategy, and by doing that, we were able to really shift the way we provided vaccines. And it's pretty cool when at the White House press briefing, they actually say the city of Atlanta had the most equitable vaccine rollout for Mpox. And that's when you know, okay, maybe we made a few right decisions in the middle of what felt like a really tense time. And then you get to do things like go hang out with the mayor. And so this was my outbreak response team for Mpox. And some of the things that we did were go to all the mayor's pride events and make sure that we were doing vaccine distribution there. That was not our primary population that we were really trying to support, but it was certainly a population that was very interested in Mpox education. And the mayor was really kind to let us tag along to all the events. All right, so now let's talk about science communication a bit, and let's talk about what it's been like to try to do science communication in the middle of 2 or 3 different pandemics or epidemics that are circulating at the same time. I'm going to spend a moment on misinformation, a little tiny bit on social media and how it's our friend or our foe, some of the inherent trust deficits that we saw probably existed, but certainly widened at the beginning of the pandemic and based on the pandemic. And then we're going to walk through some of the current work I'm doing, which is how can we be a better group of science communicators? So certainly the reason why we talk about science communication more, I think, today than we might have 5 or 6 years ago is this really intense increasing prevalence of mis and disinformation that we see circulating. It was growing when you go back and look at things over time prior to the COVID pandemic, but it just exploded at the beginning of the COVID pandemic. And I'm going to tell you a couple of my thoughts about why I think it took off so quickly. But as a result, what we see is underserved communities in particular with limited access to multiple avenues of information can get really stuck in a space where people are pouring in bad information. And why people are doing that is not going to be the focus of what I'm talking about, but more like how that's happening. And so misinformation and disinformation, for a moment, let's disaggregate what those are. They are not a fact and fiction strategy, but misinformation is bad information that just gets out there, and it maybe gets amplified, and maybe it's just slightly wrong. Maybe it's a lot wrong, but someone misunderstood something, but it's not necessarily intentional. So amplification of inaccurate or perhaps even bad information. Disinformation actually has a worse underbelly. It is information that's wrong and then intentionally distributed. And so we've got both happening, and we really need to figure out how to address both of these, even though they kind of come from different places. There's been a lot of work trying to figure out how misinformation circulates, and I'm just going to show you one particular study that looked at a bunch of different social media sites, just to give you a flavor of some of this. Overall, they found that 28.8% of social media posts reviewed in the study in the first year of COVID were classified or should be classified as misinformation. They did not separate disinformation from misinformation in the study, but just a couple of things I'll show you. 942 tweets suggesting COVID-19 is a biological weapon, and videos of people seizing, falling down, started circulating. 942 primary tweets were then retweeted almost 60,000 times in one day. That is a ton of videos that are going to be out there, and then imagine what the next day looks like. If it gets amplified that fast in one day, that's very harmful if that's not accurate information. A couple others I pulled out. In 2 days, there were over 1,923 individual tweets about unproven treatments for COVID-19. We didn't have treatments in February of 2000, so certainly, 2020, so anything that was circulating was certainly not tested. Same 2 days, 1,923 tweets discrediting official information. So I'm going to talk in a moment about some of my thoughts about some of the information that public health people were putting out, but certainly public health people were putting out the information they thought was the most accurate at the time. And so discrediting that information is also perhaps a problem unless we have a reason to believe it should be discredited. And then 2,328 tweets connecting 5G antenna and COVID-19. I cannot begin to tell you the number of times that someone said to me, I'm not positive I want a COVID vaccine because I think you're going to put a 5G marker in me, and always while holding a phone that is certainly tracking us. I always have a phone in my hand too, except for when I'm giving lectures. So that was a very, very prevalent concept. So, and then you have all sorts of other things that are circulating that are out there that, are about, please go take this horse medication. Consider ingesting bleach. Consider this, consider that. All of those things have harm. All of those things have risk if they are not proven or even just thought to have some actual sort of support or protection for someone who is suffering from COVID-19. And then, people with very large followings putting out things about this is a planned pandemic, that this is intentional, and getting that information circulating is dangerous. And then concurrently, and I'm an epidemiologist, I'm not going to say that this is causal, but concurrently what we see is this correlated drop in life expectancy, which we are not used to seeing in the United States. And it was a pretty precipitous drop. Certainly we had people dying of COVID-19, and that is awful and sad. But could we have prevented some of those deaths? And the answer is, yeah, absolutely, we could have. And some of this misinformation probably contributed to some of the loss of life that we saw. And now the change in life expectancy that all of us have. What you see here is by natal sex and the change in life expectancy. And what you see here is the excess mortality that the United States suffered. This is cumulative deaths, and this is only looking at not number of deaths, but the excess. So how many deaths would we anticipate seeing on any given year in the United States versus how many we actually saw? Recognizing we were living through a pandemic, but excess deaths, ours were disproportionate compared to a lot of other countries. I have not put the entire world on here as a comparison, but I promise you I have not hidden countries that did substantially worse than us. And we don't normally track with Russia on most of our health outcomes, but we were right together on that. And the countries we would normally be considering comparing ourselves to with health outcomes, Italy, Germany, United Kingdom, et cetera, you see are very, very different down there at the bottom. And then New Zealand, which it's easy to have some good health prevention when you're an island and you can kind of shut down your island, but had some exquisite messaging from leadership. I mean, just masterclass messaging. You see almost no excess loss of life in New Zealand. Okay, this slide is not meant to be political. I do stand by the fact that public health is always political in nature. And hopefully is not partisan in nature. But what I want to show you is how confusing we are. This is a screenshot of CNN, and this is from one of the White House briefings of COVID-19, where the President of the United States said COVID will not be here in the fall. And here's his actual quote. And then immediately you see Dr. Fauci, who's the next person to the microphone, saying COVID will be here in the fall. And if you are not in public health, or even if you're in public health and not doing COVID-19, we all have moms and dads and people who are going to call us and say, what do I do with that? How concerned should I be? When we are that messy with our messaging, it has an impact, and its impact is huge and will probably be something that we'll be talking about a decade from now, or maybe even 2 decades from now. And that impact is both loss of life, but it's also a trust deficit. And so I was asked in the student group earlier today what some of my challenges have been in a career in public health. And one of my most recent challenges is twofold I was sharing with them. One is being so surprised that people would think that I wasn't trustworthy in trying to do the right thing. I'm constantly like, why would you think I was trying to mislead you? And trying to not take that personally, although I do, and then trying to figure out why we didn't care what happened to our neighbors. Those have been 2 of my biggest challenges in the past 4 years. But this trust deficit, again, I said earlier, was not new with COVID-19, but boy, we blew the top off of it. And so this is a study from the Robert Wood Johnson Foundation looking, and Harvard together. This is looking at 2020 data. So this is it actually goes through a little bit of 2021, but this is the beginning of the pandemic. And what you see are that 72% of Americans do believe that the federal public health institutions are important when it comes to our nation's healthcare and our health. but less than 40% of them actually trust us. That is not a great approval rating for a group of people that I don't actually think ever tracked our approval ratings before. And so that was a little disheartening to figure out that people didn't necessarily think that our careers were about trying to do the right thing for the communities that we work in. And this is one of the quotes from this particular survey. A woman in Arizona, she owns a construction company, she's 60 years of age, and she said, your messaging is just all over the board. They say one thing 1 minute, and then they turn around and say another thing the next minute. And she kind of called it, right? We were all over the place, and that's very hard to come back from, and it's very hard to explain. I'm going to try to explain a little bit of it, but I don't know that I can explain all of it. So how do we communicate effectively? We have some really extremely good science communicators, and risk communication can be different than science communication. And what we were trying to do at the beginning of the pandemic was put risk communication strategies together with science communication strategies. As scientists, we typically are talking to other scientists, and we have a very specific way that we like to communicate. We write very long papers, we use really, really big words. Sometimes we actually throw in a figure to try to make things easier, but that's not always very digestible information. And when we're trying to talk to the public, what we need to do is really pivot in the way we communicate. So here are some primary strategies. I'm going to talk through a few of these specifically, but what is the goal of your communication? And commonly that means, who are you trying to actually speak to? And what are you trying to promote? Are you trying to change a behavior? Are you trying to help them consider a vaccination? Or are you trying to help them figure out how to stay safe in the middle of something that might be really scary? Starting with our most important information. We're not always really good at that in science. We sometimes really bury the lead. We also can be very jargony, and that's not a great way for us to show our skills. And we're not always relatable, but the more relatable we are, the better our messaging will be. So I'm going to talk through a few of these things. So identifying the goals of communication. There are a lot of different reasons why we might choose to be trying to communicate about our work, or how we would hope we can help the public stay safe in particular scenarios. Perhaps we're actually trying to advocate. Some great questions from the students earlier about how do you translate some of your information. Like if you're doing a study, how would you get that into the hands of a clinician in a way that's digestible and usable, or maybe even a policymaker? Those are different styles of communicating than talking to a community that might be really feeling a large burden of risk. Building that trust, and how can you on the ground in real time do things that will help support the concept that you might be trustworthy. And some of the work we did with COVID-19 out in the communities was, we spent a lot of time down at Woodruff Park, which is a very vibrant community of people experiencing homelessness or housing instability on the weekends. And the first time we rolled in there, everyone kind of looked at us and they're like, I wonder what Emory's doing, setting up a bunch of things over there, and why are they here? And so our goal of that particular day was, would anyone talk to us? And were we able to hear what their concerns might be? When we came back the next weekend, they were a little bit more interested in why we were back. And we kept going back because it showed, I thought, that we cared. And it showed that we were going to continue to come and we were going to continue to answer questions. And the student team at the time, we were doing both testing and vaccinations. The student team at the time was getting fairly demoralized, and we weren't actually vaccinating a lot of people. And so we pivoted and said, what if our goal is having a conversation? And what if the vaccine follows that? Great. But if the conversation is, how can I be here to hear what you are concerned about? And how can I try to have the right information for you? That really shifts the goal of that communication into a place that I think is a little bit more meaningful for what we had going on at the time. Certainly, you're always trying to correct mis and disinformation, but just charging in and saying, here's what I know and here's why I think you need to know what I know, is not always a very effective method to communicate. Knowing your audience, what do they care about? And so in public health, we have a lot of different communities that we might be communicating with. The way I communicate here today would be very different than the way I might teach a class, would be very different from a way that I might talk to people about their concerns about COVID. The way I did a lot of town halls for different businesses that were wanted their employees to have the information about COVID-19, hopefully good information. The way I did those is really different than the way I might talk to a community when I'm actually out in the community working with them. So you have to be able to pivot, and that doesn't mean sharing different information or changing your information. It means sharing what's relevant to the community that's in front of you. And that's really important to try to figure out and think about in advance. And I said earlier, as scientists, we often bury the lead. When you think about how we write papers, we spend the first part of our paper talking about what other people have done and why it's really important. And then we spend a little bit of time telling about what we did. And then at the very end, we tell people why we think it matters. When we're doing science communication to not our science colleagues, we actually should totally flip that. We need to start with what matters, why are we here, what are we going to be talking about, and we may not get to a bunch of that other stuff that we would normally do. So I think that we have to flip how we start most of our science communication for it to actually make sense and feel relevant. And a ton of science communication is not about actually being the person talking. It's about being the person who is there, perhaps asking some questions and figuring out what's relevant. When I first started doing town halls for businesses and different organizations and community groups for COVID-19, all on Zoom, I would start with a presentation and then I would take questions. But those questions helped inform what I should have been talking about. And so really, it should have gone the other direction. Or maybe I could have started with a little bit of information and then gone to questions, because the most important things I was able to share or think about with people were coming from the questions, not coming from what I had put together in advance. And so recognizing the community needs to lead us most of the time. And then storytelling. Why does something matter? What we know is if we can't see ourselves in the information, if we can't figure out why it's relevant to us, we commonly don't engage with it well. And some of our best methods of making sure that people can see themselves in the information we're talking about is to tell stories. And so a lot of scientists are not storytellers naturally, but we all have stories to tell. We all have ways that things make a difference to us personally, and sharing that really can be quite compelling when we're trying to talk to someone, particularly if we're trying to help change a health behavior to a way that we think might improve health. And so I really urge you all to think about how to make what we talk about really compelling to the group that you're talking with. Maybe not. Maybe the science process matters, maybe it doesn't. The beginning of vaccine rollout for COVID-19, we as people who were doing this work were wildly impressed with ourselves with Operation Warp Speed. And Operation Warp Speed carried a title that was kind of cool, right? Sounded very new, like science fiction-y for most of us. It was a scary title for most people in the community who didn't know what was going on, because it sounded like we cut a lot of corners. It sounded like we were making decisions really wickedly fast, and what we were providing may not be safe. And so that was not the point of that name, I'm certain, but we didn't explain what actually had changed and how we were able to do what would normally be 6 to 10 years worth of clinical trials in 10 months. And so if you don't explain it, you can understand why there is some concern. Additionally, we were changing what we were saying on a regular basis. So now I'm going to step into why I think some of this stuff didn't go so well. New CDC guidance. So when I came home from Alaska, what I saw was my family. I felt, by the way, like I was walking into some totally different world where we were stockpiling toilet paper, and the mail sat in the garage for 36 hours, and the groceries sat there too. I'm not really positive that was a great idea. And we were cleaning everything with bleach, and I kept thinking, fomites? We really were totally invested in the idea that we were going to get all this from surface touching. And then all of a sudden everyone was like, nope, it's respiratory, please stay 6 feet away from each other. But we trained everyone to bleach everything. And so why did we pivot? And what did we learn? Sure, we learned good things and we had a reason to pivot, but no one really explained it super well. And so what we saw over and over again, all sorts of really important policy changes that were based on good information and the iterative process of science. We learned more, we change, we adapt. That's what we should be doing. But what we did not do well consistently is say, we're pivoting and here's why. And so a little bit of an explanation may have gone a very long way from 10 days of isolation. Oh, now it's 5. Oh, only 5 if you have access to an antigen test at your house. Explain what have we learned, what's new, and why do we think it's different? It doesn't have to be a whole in-depth conversation, but we owe our audiences that information. So when you pivot like that and don't explain the why, I think it continues to erode trust even more. And then always the big picture. What's the impact? Why does this matter? We're really a society that likes to other people and things. I don't see myself in that. I don't think I have the risk. You have more risk than I do. I can be over here and be protected. So what's the big picture? Why does your health matter to me? Why am I engaged in this? Why does your health matter to your next door neighbor? Explaining those big pictures and helping with those connections, I think, is something we don't do particularly well, and something that I think that we have to do better if we're going to improve public health in this country. So in general, I kind of think of the recipe of the science communication as highlight the problem you're trying to solve, focus on the big picture, and then if you get questions that are more about the minutia, be prepared to go there. But you may not have to, or you may need to in different ways for different audiences based on the questions they ask. Describe the goals. Why are you there? What are you trying to do? What are you trying to show with your research or your policy or your protocol changes? And then explain the why, particularly if you're changing in midstream about something. Without the why, we're really losing people along the entire process. Okay, so where do I think, I told you at the beginning of my talk was pandemic reflections, the next era of epidemiology. So where do I actually think we're going in the next couple years, decade or two in epidemiology? So I'm gonna give you my thoughts on our next big epidemics, some policy changes, some response plans, and then my thoughts on, again, I'm gonna come back to trust and communication. So I showed you some of this already, but here's some different ways to look at our life expectancy loss in the United States. This is going to have a long-term effect in how we live in the United States and the health of our country. What I want to point out is that losing 1.7 years in life expectancy on aggregate is startling in the United States. But that is an aggregate number, and what we see when we look at the data in any sort of stratified way is that that is not a shared loss of life. Everyone, to be clear, you'll see in this bottom slide, everyone has some loss of life expectancy from 2020 to now compared to before 2020, but disproportionately affects people of color. And within people of color, it affects different groups very differently. When you see one group going from 71.8 years of life expectancy down into the middle 60s, they are dragging that life expectancy loss down and disproportionately bearing that risk. So we need to remember we all have this now, but we are not all equally affected, and we need to engage in how we're going to change that and how we're going to do it quickly. Also, thinking about why do we have this change in life expectancy, I do believe part of it is the pandemic. Part of it is also about the way we engaged in the pandemic and our leadership and our style of communication and our rollout of what we did with the pandemic. And again, this is back to that excess mortality risk that I showed you earlier in the slides. But what I want to point out is the U.S. so far has lost 1.1 million lives to COVID-19. That is a tremendous loss of life. And there are entire communities where people will have lost 5 to 9 people inside their family, and there are entire communities where no one may have lost a loved one. So again, inequitable loss during COVID-19, although we all deeply lost a lot during the pandemic. The world lost 6.8 million people so far to COVID-19. Those are huge numbers from a pandemic. But the United States is 4.2% of the world's population, and we are 1/7 of the loss of life from COVID-19. We normally think of ourselves as a very high economy and a very robust healthcare system, and yet we had some of the most disproportionate burden of life lost in COVID-19. And you contrast that to actually how we spend money on healthcare in the United States. We spend really high levels of money compared to our GDP on healthcare, and yet we had these tragic outcomes. And again, I cannot say often enough, disproportionately borne across communities, not consistent. And, oops, sorry. Let me go back. Okay, here we go. And I don't know if you all saw the JAMA report that came out about a month ago showing the top 10 causes of death in the United States. COVID-19 came screeching in at number 3 for causes of death in the United States. For a moment, we should all just think about that. A novel virus came in and was the 3rd leading cause of death in the United States from the very moment we had it. That is staggering. It's now dropped. It's dropped to 10. But it remains in our top 10 causes of death. And it did have an impact on other causes of death. Some things had to shift, of course. Heart disease and cancer stayed in 1 and 2 and have gone up over time during these same times, but stayed in the same place. But we see some other things also changing. We see suicide having some changes. We see kidney disease having some changes. But what I really want to point out are these unintentional injuries and how and what that category actually includes. I'm going to do it looking at these data. So what you have over on the left side are deaths due to medical causes, and what you have on the right side are deaths due to external causes. This is going from 2000 to 2022, so not completely covering the same amount of time, but what you see is this drug overdose line going up at a really, really rapid rate. So as I think about the next places to work in public health, the big things that we've got coming that we need to learn how to tackle, our life expectancy loss is huge. Our life expectancy loss is multifactorial for sure, but this is one of those massive drivers. And so working on our opioid epidemic in this country, to me, is one of the pandemics, hopefully not a pandemic, but at least an epidemic we need to be talking about. So as we think about opioid use, a little bit of data to show you. In the last 20 years, the U.S. has experienced a really growing crisis in our abuse and addiction deaths and drug overdoses. And since 2000, the annual number of overdose deaths has gone up by 6-fold. That is huge in just 24 years. And most of those have involved opioids of some variety, synthetic or non-synthetic opioids, and fentanyl and related synthetic opioids have accounted for almost 71,000 drug overdoses just since 2021. That is a staggering amount of drug overdose that we're seeing in this country, and an epidemic where we need a lot of engagement and work. I also think this is by no means my area of expertise, but I think if you're interested in any sort of rollout of epidemics and pandemics, you have to be considering how the climate change and climate crisis is affecting all of our health. It increases our rate of injury, our rate of suicide, our rate of mental health conditions, our heart disease, our strokes, our zoonotic diseases. It is just one thing after another, and our housing and how we are in communities together and what is a safe community. So almost everything that you might want to think about in public health is going to be affected by this. Plus, we're going to have climate migrants, and that's going to be a whole nother world of work to be working in. Turning for a moment about some impacts of policies, reproductive rights and maternal morbidity. This is a map of the United States looking at the rollout of abortion bans or other reproductive right bans going on across the United States. And what you see are widespread, 14 states have abortion bans that have been rolled out very, very recently. And we're starting to see some data. How does that impact our life? And what I'm just going to point out, Texas, maternal deaths in Texas skyrocketed. This is brand new data that came out this week. Skyrocketed after the state's 2021 abortion ban, rising by 56%. 56% compared to a U.S. aggregate 11% increase. Again, correlated, can't say it's causation, but I would be hard pressed to not believe that there is a very positive correlation going on here. And then other policy issues. We've got a Medicaid gap in the United States, and particularly in the state we're sitting in. There are 10 states that have not expanded Medicaid. And so what does that actually mean? Well, when the Affordable Care Act was rolled out, what we saw is 20 to 24 million people, estimates, were all of a sudden eligible for insurance that didn't have insurance before. 20 to 24 million people were added to insurance programs. And it was a combination of both more the network of insurance options, but also the Affordable Care Act. Massive increase in people with insurance. But as of April of 2024, 10 states didn't adopt it. And so here's what that does. The Medicaid gap is 1.9 million people in this country in these 10 states who are at a poverty level where they're not going to be eligible for Medicaid at the way the state currently frames access based on poverty, but do not make enough money to be able to get insurance. So they sit between in this no man's land of I can't get Medicaid because you've not raised the amount, and I can't get insurance because I don't make enough. So that is a working poverty level that doesn't have access. And 1.6 million, not 1.9 million people sit in these 10 states that now don't have access to this that would if it were expanded. And again, to show expanding Medicaid to 138% of the federal poverty level, which would only be expanding it to an annual income of just barely over $20,000 for an individual in 2024, would increase health insurance coverage, reduce racial and ethnic health inequities, and improve healthcare access, health outcomes, and financial security for people in communities that actually are most at risk for many of the things that we should be very, very concerned about in our country. Again, inequitable, right? So that's a consistent theme through all of these things. And then we have a call for entire governing bodies that do public health work to be shut down. So by no means have I read all of Project 2025, but I do want to point out what it talks about for CDC. So CDC is here in our city, and it would call for CDC to be split into two different entities with a firewall in between, so they wouldn't be able to share data. It also has differences in the way they can produce data, the type of data they can collect, the type of data they could not collect, and says things like that the CDC would not be able to make any statements or issue any kind of information based on public health advice. I think that is staggering to consider because that's actually the mission of what CDC is to do. And the person who wrote this particular part says CDC is perhaps the most incompetent and arrogant agency in the entire federal government. I do not work at the CDC. I have a lot of friends who do. I'm not saying it's perfect. There were a lot of policy changes that came out of CDC during COVID-19 that I questioned, or I questioned the way that they were put out and the things that were said about it. But it does not mean really good work is being done there. And so to strip our country at a time of a public health crisis of the governing body that should be thinking about our public health in its entirety seems wildly dangerous. So what should a public health response readiness plan look like? So as we think about what we should be doing, so our national plan, which we certainly need, and we should be putting those together at a time when we are not quite in crisis, the way you are at the beginning of a pandemic. But any sort of work that you might do that would be about preparedness would be to think about who your partners are and how do you stabilize and enhance those partnerships before you're in need, which means consistently engaging, consistently being a partner all the time, in the good times and the hard times. Expanding your local support system, improving your administrative system so that you're up and running in case something bad happens. Building your workforce capacity. Some of the questions that students had earlier were about, like, where are the jobs in public health? Oh my goodness, state and local health departments. Boy, do they need us and need you. Modernizing data collection and systems so that, again, so we're doing the best work we can possibly do and ready should something else happen. Strengthening our communications activities, which is a lot of the work I'm trying to think about, incorporating health equity practices in every single thing we do. advancing capacity of our public health laboratory systems so that they're up and running and have the best technology possible, and then prioritizing community recovery. So it's one thing to work through an emergency with someone, but who's there afterwards? And what are they doing to help pick up the pieces or put things back together for people, and giving that support that people are saying that they need. And then lastly, I'll go back to trust and communication, because I think that they're the foundation of everything that we need to be thinking about to improve health in this country. So how do you build community trust? You can't rush it. You can't walk in and say, hey, I'm Jodie Guest. I really am here to help you. You should trust me. I need to prove that I should be trusted. And all of us need to do that. And so how do you engage with the public on a regular basis in a way that is really, really honest about, again, what you know, what you don't know, why you don't know something, and if you're ever possibly going to be able to get back to knowing that. How do you keep the public safe? And how do you think about that? How do you offer autonomy to the public? There wasn't a lot of autonomy in a couple of the original decisions about COVID-19 and the way we would enact those policies. And so where is the balance in autonomy versus emergencies? Recognizing that trust is shaped by both emotion and rational thought. So a lot of our connections are not just because you've got great information. It's about somehow you've made a human connection with someone. And representing, how do you represent the public's best interest, and how do you work towards a net benefit for everyone, which means some groups may need more than other groups. It's inequities that we're talking about, not equality that we're trying to get towards. Those are different concepts. And then the art of science communication. So why does it matter so much? It's really necessary to address emerging challenges to the way the public receives and consumes information. And again, with the students, we were talking earlier about social media, and where should we be presenting science information that is usable and digestible and important? Wherever anyone is. So if they're all on TikTok, I need a TikTok account, or I need to work with someone who has one because they would be better at it than I would. And how do we make sure that we're the right person doing that? Because what we're really all about in public health, we're about improving the world's health, right? And so if we stay in our silos, we're not going to get that information out there. So if everyone wants their news on Instagram, guess where that news needs to be? It needs to be on Instagram, and we need to do it really, really well. And we need to be doing it in a way that our messaging can be amplified just as much as anyone else's messaging. And I don't think public health was very ready for the impact of social media and the way we communicate. And so we have catching up to do, but boy, we've got to do it fast, and we have to learn how to do it really well, which probably means we need our younger colleagues to help us and lead us in that. So I'll leave you with this picture. This is Milledgeville, where they actually came and tried to arrest us and said we were kidnapping people when we were trying to actually do COVID-19 vaccinations. And the way we got around that was when the police arrived and saw what we were doing, they actually brought the whole police force out and let us do COVID testing on them. And then got it on the news, but I promise we were not trying to kidnap people and take them home with us. But I appreciate your attention and you being here today and letting me share a little bit of the work that we did in COVID and kind of my musings of where I think we need to be going in public health. So I would love some questions.
Hello?
Hi.
I wanted to say that was a fantastic presentation.
Thank you.
Just actually a quick question on how you all changed your approach to rolling out vaccines for monkeypox. I know you mentioned when we first started rolling this out, this wasn't really hitting the communities that were most affected by it. And wanted to hear more about how you changed
Sure.
your approach.
Yeah, so what we used at the beginning was the vaccination sign-up form that was being used in Fulton County and DeKalb County for COVID vaccines. And so that was a very computer-oriented system, and so that just felt really like the most obvious thing to use. Again, when we saw the distribution of, by race and ethnicity of the group that signed up, what we recognized was having it wide open was probably not what we needed to do with our first couple of rounds of vaccines that we had available. So instead we went and we did a couple things. We started going to partnering with Black, gay, social groups in Atlanta and making sure that we had signups available there. So we took it off of online. And we started marketing on Grindr, and we actually did a Grindr and MARTA campaign, and tried to get the information to the communities that we felt needed the vaccines the most. But a lot of it was going to social networking groups and saying, what's your listserv look like? How do you get information out to people? And would you be willing to help us do this? And here's why it matters that we get this information to the community. The timing was such that in Atlanta, it was pre-Pride, and so we used a lot of the pre-Pride social events as places to talk about Mpox risk and have vaccines available. Yeah, you're welcome.
I'll echo the thanks that you already heard.
Thank you.
Both for your presentation and for your powerful leadership, both during the pandemic and now. It seems to me that a common theme that goes through your talk is humility. And both humility in the way that you engage with communities and humility in the ways that you approach communication and kind of addressing the public more broadly as a public health leader. I'm wondering where you think the opportunities are. I mean, obviously, modeling that humility is powerful. But where do you think the beyond you personally modeling it, where the opportunities are to teach that to colleagues and students in academia and beyond?
Well, thank you. That's a huge compliment, so I appreciate that. Sorry. I think I'm building a science communication a certificate and fellowship at Emory currently, and hoping to get approval by Friday. And so one of the things we're doing is having our students work in working on a team about how to practice science communication. And what we're going to do is have external community groups that need help with communication or would like to try different styles of communication, actually work with our students. And so I think one of the best, I think practice, right? But what we're going to do is say, you can't just build this information. You actually have to go out and meet everyone and spend a little time there first. And if you don't do that, I think communications can commonly miss the mark. And so we're going to try to take a flipped approach of go out and meet and get to know people and then practice your communication skills. So it's all going to be about keeping your mouth shut, let's listen, and learn, and then go out. So we're trying to model that. And one of the things I will say is, the work we did, and it was such a privilege to be able to be in the communities that we were in. The bell curve of access, particularly when you think about COVID vaccines in the city of Atlanta, the work David Holland did building the Mercedes-Benz vaccination site was incredible. Such a gift to the city, the way he put that together. And that covered about 80% of the people who should have had access to that vaccination site. What we did was try to work with the communities that were on either ends of that bell curve that didn't fit. And that is a little bit more intense work. It's a lot more labor for fewer people, but so very worth it. And so I hope as we think about things with science communication, we will learn to take both approaches, the mass information and then the very specialized, more intentional, harder work information as well. And then trying to pair up, where do students find their passion? Are they interested in this, mass thing, or are they interested in this more niche? And we need both, and then supporting both.
Hi, I have a question about one of the things that.
Yeah, I can hear. Yes. Yeah. Before, which is humility. We can have humility with our data as well. This is the best data that we have. Might be one way to talk about it. This is the best we have right now. We're trying to make it better. So it's recognizing back to the what do you know, what do you don't know, and how can you change that. I also think it's talking about the fact that science is meant to be iterative. We are meant to consistently be asking the same questions over and over again and learning more and more. And if we make declarations, we don't allow for that iterative process and for us to sound like we know what we're doing when we change. And so imagine you've got pandemic X coming your way, and you are doing risk communication at the beginning. There's that balance of how fast do you say something versus how much do you need to know in order to say something. So you put something out, and maybe a week or two later you learn something different, and you need to change what you said before. Explain the change. Explain how the data changed. Explain what you didn't know before, and then why this is what you think now. And I think there is a reaction to, if I show that I didn't know before, I'm showing I made a mistake, or I don't sound trustworthy. I actually think you build trust with that rather than losing it. And so again, it's a mind shift of, I think our audiences are owed that explanation, and we shouldn't bury them in our methods and in all of our results, but we should highlight our uncertainties when we have them.
I'm going to avoid a microphone, but I was just thank you again, Dr.
Yeah.
Guest, and thanks to the audience, and we really enjoyed your talk, and especially your focus on the communities that included us.
Thank you. Thank you again so much for being here.